Good afternoon. We're going to call the meeting to order at this time, and this is our Severe Mental Illness Task Force meeting number 2, and I think most of you have the agenda in front of you and have a folder of information. I'm going to ask if the secretary would please call the roll.
Senator Berg, Senator Meredith, Representative Fleming, Representative Gibbons-Prunty, Representative Wilner. So I just realized I forgot Senator Alvarado. I apologize.
No problem. Present in the room.
Co-Chair Kerr.
I'm present in the room.
And Co-Chair Bentley.
Present in the room.
Well, we really appreciate you all being here today. Thank you to my co-chair, Representative Bentley. And again, it is amazing. As I looked around when I heard who they had put down on the list to serve in this committee, I thought how ironic that all the really good-looking people in the legislature were the ones that were chosen to make up this body. Amen. Amen. Absolutely, Steve. I'm going to go ahead and hopefully we have our first guest with us, and this is Dr. Robert Mccarron, and he's professor and vice chair of psychiatry and human behavior at the University of California, Irvine. And if you can bring him up, however that occurs, does he just snap up?
Yep, he's just shared his screen.
Okay, and so I can't really see him, but am I not supposed to face? I'm seeing his.
I think when he speaks.
Okay. Well, I just told you a couple of sentences because a very close friend of the doctor is with us today, and that is Dr. Alvarado. And so I've asked him if he would give the full-blown introduction for our special guest.
Thank you, Madam Chairman. I appreciate that, and it's an honor for me, really, and it's a privilege. Dr. Mccarron and I have probably known each other, Robert, I don't know, probably 35 years. We went to college together, and one of my oldest and dearest friends, and it's interesting that a lot of the guys that I hung out with in college wound up going into medical or dental fields. And Dr. Mccarron is, you can see his bio in your packet.
Senator Alvarado, before you keep going,
yes,
can we just ask if our guest can hear us?
Yeah, I can hear you. Can you hear me okay?
Yes, now we can. I just wanted to make sure because I hadn't heard you yet. So welcome. And Dr. Alvarado, please continue.
Thank you. So again, I won't read the entire bio, but a dear friend who's become a very accomplished author in the field of primary care and in psychiatry. He did a combined residency, I know, at Rush, I believe, in Chicago. And there's a lot of combined residency individuals, but he did them in both. And and found himself now, we went to UC Davis, now at UC Irvine, and is really the kind of the department of psychiatry and behavioral medicine, assistant dean there at UCI. And again, he's a published author on topics that are important for primary care doctors and that try to do psychiatry as well. He and I have had many discussions at times about this topic and about the difficulties that we have in Kentucky and in rural America in general of trying to attract psychiatrists and people to kind of handle severe mental illness. I've often discussed with him my reluctance to handle those things as a primary care doctor for years. I just didn't feel comfortable with it. And he talked about a program that he had developed in California that he petitioned the General Assembly in California to start up. And I think we're going to hear about that discussion today, and that he claims is doing very, very well. He's got some good data to present to us, and he had asked me several times. He says, I think we can really do a lot of the same benefits we're seeing in rural California here in Kentucky to try to help enhance primary care doctors to do and feel comfortable in treating individuals with moderate to severe psychiatric diagnoses, and then to help them also teach their colleagues to do the same thing. And so he's asked me several times. When this task force was established, Madam Chair, I was very excited because I thought this would be, in our first meeting, we had the discussion, the topic of the shortage, and that's when I thought I would bring this up. So I'm very excited to have Dr. Mccarron presenting for us today. And so with that, Madam Chair, Dr. Mccarron, if you're there, if you'd like to introduce yourself for the record and begin your testimony.
Well, thank you, Senator Alvarado, and thanks for the nice introduction. I really appreciate your help. And everything you're doing in Kentucky, by the way. I've seen you, from your first campaign till now, and very proud of, about the work that you've been doing with Kentucky. Awesome work. So it's a pleasure to briefly speak with all of you, and I want to give a special thanks to Samir, who arranged all of this, and to the co-chair, Senator Kerr and Representative Bentley, as well as the rest of the task force members. It's really a real pleasure for me to meet with you. I'd like to just kind of jump into to this brief sort of summary, and break it down into two core areas. And the first area is the problem, or what I think might be the problem from a statewide standpoint. I can relate because we're seeing something similar in California, although in some ways different. And then I'd like to talk about a possible solution for the state of Kentucky. Certainly not a solution that's going to fix everything, but I think a solution that is evidence-based and will make a difference. Let's start with fairly recent data from January of 2021 from the Health Resources and Services Administration, looking at health professional shortage areas in mental health. And if you look at the state of Kentucky, the blue is the highest level of need. And you can see that every inch of the state has a health professional shortage area in mental health. Every area, every county. And certainly most of the state has a significant shortage. You all know this, and I won't speak a lot about it other than to say a few things. If you look at all of the psychiatrists throughout the country, you'll see that about 70% of them are over the age of 50. And if you look at data in the state of California, where we actually have almost 6,000 psychiatrists for the state of California, still not enough, right? We see that the total number of psychiatrists, if you look at the total number of psychiatrists, about 45% of them are over the age of 60 and looking for retirement. So we definitely have a shortage, no question about it. The solution nationwide in my lifetime, and probably another lifetime after that, is probably not going to be creating more residency programs. There certainly is a lack of funding nationwide, and certainly that's not going to be the main answer for a myriad of reasons. If we look at your state, we see that there are about 350 actively practicing psychiatrists, or 8 per 100,000. Ideally, you're looking at a need of 50 plus per 100,000. And so you already know this, I think, ergo the task force that you're on, there's a shortage. And here's the deal. Even if there wasn't a shortage, let's say there wasn't, which there is, primary care providers are the psychiatric workforce. They make up the psychiatric workforce, period. Patients are not going to go to a psychiatrist. They're not going to go to a psychologist, a social worker, et cetera. They are going to be presenting with common psychiatric complaints to their primary care provider. Now, unfortunately, there's a high burnout rate nationwide, and that includes Kentucky. Lack of training is a big, big deal. As Senator Alvarado said, I'm an internal medicine doc as well as a psychiatrist. And let me give you some perspective, right? For internal medicine, in order to sit for your boards through the American Board of Internal Medicine, there has to be certain criteria met in terms of education, right? And if you look at hours spent or days or months spent training in psychiatry, that number is 0. So there's 0 time required for actual clinical experiences during 3 years of training for a potential internal medicine primary care provider. In the state of California, 2 weeks is the required amount of time for physician assistants. So there's really a lack of training, and I would say under 2 important domains. And I know with Dr. Alvarado, he's mentioned that both of these domains are unsettling, for him and many PCPs, probably because of lack of training and experience. Those 2 areas include primary care-based psychiatry and chronic pain management. Certainly, there are cultural barriers, and both providers, legislators, and patients have stigma against mental health, myself included. And there's plenty of data to support that. Briefly looking at the problem here, if you look at Kentucky, this upper line versus the United States, this lower line here, percentage of adults who have been told by a health professional that they have a problem with depression, we can see the numbers are quite high. Looking back to 2019, 25%, much higher than the national average. If you look at the national average and comparing different states, and you look at Kentucky in particular, and really the question is, who has the highest percentage of adults reporting symptoms of anxiety and or depression during the pandemic in this particular case for about a month during the spring of the pandemic. Kentucky reported the second highest at 35.2%. This is national data looking at the share of adults with mental illness, any type of mental illness. And we see Kentucky, unfortunately, presents on the high side at about 24% of the patient population. Opioids, I won't go into detail here. This is just CDC data looking at a number of overdose deaths in Kentucky. And fortunately, we're seeing a little bit of a downswing since about 2018, but the numbers are high, and they're much higher in Kentucky, unfortunately. Let's look at opioid overdose death rates. Again, per 100,000 citizens, and we see Kentucky is much higher than the United States. Again, here, most recent data, 2019, per CDC information, looking at about 25 per 100,000. These numbers are very high. They're very, very high. And if you compare Kentucky with the rest of the states, they're very high. Domestic violence, a problem in Kentucky. From the data that I see, this has increased during the pandemic. Just one piece of information to illustrate this, about 45% of women and 35% of men in Kentucky reported physical violence, intimate partner violence during their lifetime. Kentucky has the 11th highest femicide rate in the United States. Now, a lot of times people will find it easy to separate general medical conditions like cancer, obesity, heart disease, et cetera, from mental health conditions. But there's plenty of data to show that's really not the case. In fact, general medical conditions are closely linked with severe mental illness. And that's why those who have severe mental illness or SMI die 2 to 3 decades earlier relative to the general patient population, 2 to 3 decades. Now, with that comes pronounced level of disability before a premature death. These are some state rankings. I'm sure you are probably familiar with some of these. Again, closely linked with mental health in many ways. Smoking, Kentucky is at the top of the list. Obesity, diabetes, cancer-related deaths, also very high among Kentucky residents relative to other states. Cardiovascular disease, uninsured patients, Kentucky ranks number 30. And so these general medical conditions, again, closely linked with severe mental illness. Recently, Kentucky was ranked 48th and 49th among states for the average number of days a person could not perform work or household tasks due to mental health or physical health issues, respectively. Again, looking at disability, right? We do see that depression is the number one cause of disability in this country. In fact, we see from CDC data that about a third, a little over a third of those from Kentucky will have disability at least once in their lifetime. Now, the problem, again, to summarize, as I called the 5 Ds, are all connected under the umbrella of mental health. Depression, also oftentimes anxiety with that, domestic violence, drug use, mainly opioids, disability, and premature death. To go a little bit further, again, about 3/4 of all psychiatric care in this country, probably more in Kentucky, is provided by primary care physicians and providers. On any given day, about 40% of a PCP's day is related to significant psychiatric issues. Now, you can refer these patients, but about half the time, at least half the time, those referrals are not going to happen for a myriad of reasons, including stigma, poverty, cultural issues, paucity of psychiatrists, et cetera. And so this is a huge problem, right? Now, I mentioned earlier that depression is the number one cause of disability. Suicide rates are going up. And unfortunately, our providers in primary care settings are just not trained. They're not trained. They're writing over 80% of the antidepressant prescriptions, but they're not trained on how to do this, unfortunately. About half psychiatrists take cash only, probably more in certain parts of Kentucky, I imagine. Bottom line, 60% of those suffering are not receiving treatment. So here's part of the solution, part of my proposal here for you to consider as a task force. Education, unique, targeted, evidence-based education can result in increased workforce, better health outcomes, and again, a possible solution in Kentucky. A quick overview on the UC Irvine Train New Trainers Primary Care Psychiatry Fellowship, which was started in 2016. This program is a 1-year program that provides a very targeted overview on what PCPs see most on any given day in terms of mental health issues. We provide a quick and targeted overview on the psychiatric exam, common psychiatric conditions. The training is outside of normal clinic hours, so the PCP can still be a primary care provider and get this training. The focus is on improved health outcomes.
Doctor, we've got another 5 minutes. Just wanted to give you a heads up.
Thank you. They learn when to refer, and then of course there's multiple hours with CME. The other thing that's unique about this is when these folks graduate from our program, they, if they choose, are eligible for lifelong learning. We continue the training. It goes on and on for the rest of their career at no cost to them. They get ongoing mentorship, ongoing training. These are the three main core components of the training: 2 case-based teleeducation learning modules per month, very interactive modules, 2 intensive weekends per year, and then at least 1 hour of mentoring sessions with a faculty member. Our faculty members are duly trained in psychiatry and primary care. There's lifelong learning, like I mentioned before, and a certificate of completion. An overview of who we've trained. We expect that next year we'll be close to 300 or 400 in our class. We are likely to receive probably anywhere from $7 to $9 million from the state of California to train folks in our state. We've received just under $4 million over the last 3 years thus far to train, and the need remains high. Areas of focus I put in red for Kentucky: cultural issues, mood and anxiety issues, pain medicine, motivational interviewing as well. There's a list of our faculty. We have over 35 faculty throughout the state, throughout the country, some of whom are based in California. So some outcomes. We don't want to just put a program together and say, hey, here's our training program, right? So every year we put out an executive summary. We look at how our fellows are doing. In this case, total scores and attitude towards mental health, which have increased. Knowledge-based, looking at competency and management of psychiatric conditions, including psychopharmacology or prescription of medications, looking at pre-fellowship, midway through fellowship, and post-fellowship. Also looking at confidence in completing a psychiatric interview and teaching psychiatric topics. Let me say this. A big part of what we do is we don't just train, but we train our fellows how to train. So training someone in rural Kentucky will result in them in these alumni training other providers, and that's a big part of our program. This is other research outcomes looking at confidence in managing common psychiatric conditions, including anxiety, substance disorders, anxiety, chronic pain, suicide, and you can see the numbers go up when looking at pre, mid, and post training. Again, looking at knowledge survey, increase over pre, mid, and post. Our fellows are happy with the program. About 95% of them are satisfied or extremely satisfied. A quick overview, we have, again, a large number of dually trained faculty. No one else is doing this in the country. We have large health plans, the state of California helping us support this training. We'd love to have Kentucky on board as well. We also believe that this training will help with general medical conditions. Quickly, this is our ask. We'd love to train 75 fellows per year for about 225 fellows or so over 3 years to create T&T champions who could then leverage this training and train other folks. This would be about $1 million a year. We would recommend focusing on underserved areas in Kentucky. With this would come an annual report of research outcomes for Kentucky learners specifically. I would also be happy to do some consultation on population health in Kentucky, along with our leadership team. Long-term goal might be to train about 1,000 PCPs in underserved and rural Kentucky. I'll end with this. This is one of our recent classes, about, I think, 200 folks or so. You can see they're all smiling and happy. I want to thank all of you for listening. My sincere hope is that in some way we can help with the problem in Kentucky. Thank you very much.
Wonderful, and thank you for that presentation. We have lots of professionals on this panel, and I'm sure there's going to be questions for you. I haven't seen a hand yet, though. Does anyone? Dr. Alvarado?
Sure. Dr. Mccarron, thank you. And I guess when we've talked about this quite a bit, I know you've often said, "Hey, we're getting really good results. We're seeing people getting treated, and a lot of the issues that you've got. And people always think of California as big population basins of LA, San Diego, San Francisco, those kind of areas. And we have to remind ourselves that in the northeastern parts and the southeastern parts of the state are very rural, often matching what we see in Kentucky. Are you starting to hear, or do you have numbers or data already on patients getting treated? Have we seen a difference in terms of maybe reductions in hospitalizations, in suicide attempts, or is it too early to see that data?
Yeah, Dr. Alvarado, we're looking at that right now, actually. We're using health plans like LA Care, Inland Empire Health Plan. These are large health plans in California to draw this data, large amount of data from their EMR sets. And so we're now looking at this data. We do have data showing expansion of workforce in underserved areas like Fresno, Inland Empire, rural areas in California, and also underserved areas like Oakland, for example, in certain parts of Los Angeles, where it's really hard to find both PCPs and psychiatrists. And looking at practice pattern outcomes, that's something that we're working on right now with our partners and large health plans in California.
If we were to, so obviously this is something that would take some funding if it was going to happen, and it's to produce a psychiatrist. it takes obviously college, medical school, residency training, and then getting out. It's not like you can pop a doctor out of a gumball machine. It takes 10, 12 years to get a professional set up, or even an APRN or nurse practitioners who might choose psychiatry. Again, it takes several years of training to get them out into the workforce. This would be a quicker result. And in terms of this, like I said, the numbers is roughly 1.1 million, I guess, per year. So is that the kind of funding it would require? And how would, if we decided to do something along those lines, how would that go about? If we could allocate funds within a budget to make that happen, does it have to go through the University of California, Irvine? Is that how it would go, or how do we proceed with something like that?
Yeah, this would be basically contracted through UC Irvine, University of California, Irvine, and again, that's just my recommendation when looking at the need in Kentucky, and that's probably, from my view, a good, reasonable start. But we're certainly willing to go up or down on that either way. Again, I think Senator Alvarado, I would love to not only make but demonstrate and publish a difference in rural and underserved Kentucky. We have a large research team. We're ready to publish our first study, within the next 2 or 3 months, and we can definitely make a difference in the state of Kentucky.
Representative Wilner.
Thank you, Madam Chair. Thank you for this presentation. This was really very, very interesting and very, very helpful. I just, for folks particularly with severe mental illness, we know that what works best is a multidisciplinary approach. And I noticed one of your learning outcomes is when to refer to a mental health specialist and how best to interface with mental health colleagues. And I know sometimes folks from different professions, even if we all have the same goals of helping the patients, we speak different languages. So could you just talk a little bit about that particular objective?
Yeah, no, thanks for the question. So I'm a firm believer in really bringing disciplines together. It doesn't work better otherwise. And so, for example, we have a handful of psychologists as part of our training team. Psychologists bring something very different than psychiatrists. Social workers as well, have been part of our team in the past. And so we do believe in a multidisciplinary approach for most effective treatment.
Well, as a psychologist, I appreciate that response. So thank you very much.
Okay, thank you. We can take one more question here. I'm sorry we're on such a tight time frame today. Maybe we can have a retreat and spend the night sometime and have food and games. Senator Meredith.
Thank you. Doctor, appreciate the presentation. I'm looking at one of your slides where it has a primary care psychiatric fellowship, and it mentions the past fellows include MDs, DOs, NPs, PAs, and clinical pharmacists. So how do you kind of, for want of a better term, market this program within your home state? Do you try to look at one particular area more than others in terms of professions, or like what would attract clinical pharmacists to this program versus an MD?
So we don't market it. We really have never marketed it. We usually have a waiting list of folks each year that we have to roll over into the next year. We do our best to find scholarships for PCPs who want to learn this stuff. In terms of finding different disciplines, again, we welcome all those disciplines because we think they're all very important in terms of delivery of care, and also expanding what they're learning and bringing it to other colleagues. So interestingly enough, we don't really have a marketing campaign. This is word of mouth, and we have a lot of folks who want to learn this.
Madam Chair, can I follow up, please?
Please do.
Since you have this waiting list, is there a priority amongst the waiting list, or is it first come, first serve?
Well, it's first come, first serve, but we also review the applications. And in California, about 80% of our learners come from state-defined underserved areas. And so there's a lot of reasons for that. The two main reasons include that's part of our mission. So that's what we want. We're looking for that. We want 80 to 90% of our learners from underserved areas. But the second reason is a lot of the money that we get from health plans, Cedars-Sinai in LA, and also from the state of California in particular, share the same mission. And so those tuition dollars go towards providers who work in underserved areas.
Madam Chair, this is one of those that appears to be one of those no-brainers. Mm-hmm. Dr. Senator Alvarado made a reference to the cost factor. That always seems to be the stumbling block for everything we attempt to do. But again, you've heard me preach about there's enough money in the system already. Not providing care is the most expensive care that you can have. Secondly, is providing inappropriate care is probably the second most expensive. So the funding is there. We just have to find a way to channel it in this direction. But I think this is certainly worthwhile and would fill a gaping hole for Kentucky, particularly for a rural area. So I'm very encouraged to hear this program and would heartily endorse it. Thank you.
And thank you. And thank you, Dr. Mccarron, for sharing your knowledge with us. And I feel like that this will open up a lot of doors for us to stay in touch. And, of course, with our contacts here now with LRC and this wonderful staff and with Dr. Alvarado, I think this is good news. And so thank you. I'm sorry we had to rush through today, but happy day to you, and thank you for being a part.
Thank you so much. Have a good day.
Thank you. Next on our agenda, we have the very handsome, as he's already pointed out, Steve Shannon, who will be coming up. He is the executive. He's the executive director of the Kentucky Association of Regional Programs. And so with no further ado, Steve, I have to turn my timer on for about 12 minutes and then a few minutes for some questions. While we are paused, I didn't ask for an approval of the minutes. Thank you, Senator Meredith. And thank you, Representative.
All right. Thank you. All right.
The meetings are approved, by the way.
Appreciate
Please
it. Thank
proceed.
you. Again, I am Steve Shannon. I'm the Executive Director of Carp, Carp's an association of 11 of the 14 community mental health centers. I always start my presentation with some information about the CMHCs. Where's my little deal now? There we go, right there.
Everything's so small.
CMHCs, there's 14 in the state. They have a specific geographic territory ranging from 5 to as many as 17 counties, 55,000 people to 1 million people. We serve about 175,000 people a year, about 1 in 25 Kentuckians. We do exactly what Dr. Mccarron talked about, exactly where we're at. I had a conversation with Senator Alvarado about that topic a couple of years ago. We struggle for prescribers. We clearly need that. So I think it's an invaluable tool for us. We employ about 8,000 people. 1 in 200 working Kentuckians employed by Mental Health Center. We're an economic force. Wide range of people. We have bachelor's level, high school educated, master's level, PhDs, attorneys, accountants, doctors, APRNs, a wide range of people. And a piece we don't talk about very often is we have 300 volunteer board members across the state. Those are individuals who give their time to the CMHCs to provide guidance, direction, and support for those organizations. And they don't get a lot of credit necessarily. I really believe the CMHCs make all Kentucky communities better. We are the behavioral health public safety net. We are 24/7. We are there all the time. For your information, this is the map of Kentucky. These are the regions. There's 14 regions. In that map, there's a black bold line. Those relate to the state psychiatric hospitals that are in operation. If you look at the far western part, they go to Western State Hospital. It's Four Rivers, Pennyroyal, Life Skills. They've merged recently, but there's still 2. We count them that way. And River Valley. If you live in those counties, you go to Western State Hospital if you need involuntary commitment.
Excuse me, Steve.
Yes, sir.
I'm very confused as a co-chair. Could you explain something to me?
Yes, sir.
With your indulgence, Chair Lady.
Absolutely. Please proceed, Mr. Co-Chair.
Well, last time we defined CMHC. That's what you're defining here?
Correct.
Well, I'm confused. What is a BHSO?
BHSO is a lookalike CMHC. It's a behavioral health service organization that happened in 2014 when Medicaid was expanded and they added that licensure status. It's similar to a CMHC, not identical to a CMHC. CMHC has to have a medical director. CMHC gets state general fund for services that maybe a BHSO doesn't get to. Also, I believe, and I think the statute that created the CMHCs, it is a regional model. The word region is used in the CMHC statute, KRS 210, 370, 485, 7 or 8 times. Communities were 11 times. I believe those regions are where CMHCs ought to operate.
Do they both bill the same? Do they do the same services?
They do the same services. The rates are different for some services, primarily because we have that 24/7, 364 obligation that others do not. Again, we have to have a physician. Others do not. We have to have a medical records person. Others do not. So we have different expectations. We have an obligation. This is the big part of what we do. Community mental health center. The operative word is community. Heath. My first board meeting at Carp was a month after the Heath High School shooting. They went and responded to that. Floods we respond to. Marshall County High School, the mental health center, probably the only one in the country that responded to 2 school shootings, went to Marshall County. We do that. Other folks may do that. Other providers do that. It's a non-negotiable. Tornadoes in East Kentucky, Pathways, Center Alvarado. Their operation was not harmed in West Liberty. They became a hub for that community. Their staff went there. And that's a fundamental difference between us and other providers. I may offend other providers by that, but I really do believe that's a statutory charge. I believe our assignment is given to us by the 1964 General Assembly. It hasn't been changed in statute since then. I believe we have an obligation to those counties.
I'm still confused. A BHSO, do they practice throughout Kentucky or what?
They are not specific. They can go anywhere they want. So I've contended if you're a CMHC, you can go to another part of the state, not in the region designated, if your license has a BHSO. We asked that question of the cabinet several years ago, and we were told, I think you were in that room at the time, right? That the region is not defined specifically in regulation or statute. What those, in your case, New Vista, those 17 counties aren't written down anywhere.
Can you be both in the same place?
You can. I don't know why you would in your own region.
And both bill Medicaid?
Yes, both bill Medicaid. They can both bill Medicaid, the same service. We can use a mental health associate, which is a person under supervision, has a bachelor's degree. BHSOs can't use that. That's kind of a legacy service. So we have some people who have that bachelor's degree, and they've been approved as a mental health associate. That's a different, and some rates are different between the 2 models because of the.
And my last question, I'm sorry I interrupted on this, but why were they created?
They were created
if
to
we have
ensure,
CMHC.
And this goes back to October 31st, 1963, when President Kennedy created us. It was timely services close to home. That was the point, where people lived. And I worked for a guy for the decade who helped design those regions. His plan was 20 of them, and we ended up with 14. Pathways in your area is 2 regions, right? So that's how we get to 14 instead of 15 ad districts. And the intent was, where do people go for services now? And that was the model. I tell people the ad districts have Livingston County wrong. It's an ad 2 and Mental Health Center 1. We got it right just because I'm biased. But it was specifically designed, where do people go to access services? And how do you get a critical mass to ensure enough people to operate? 55,000 in Comprehend is how many people live there. And that's the smallest one we got. And that it functions okay.
So are they in competition?
They are
doing dual
not in
services?
competition until the last 4 or 5 years. Specifically, we're going to just put one of the regions as operations in 5 or 6 other parts of the state. It causes frustration for my members. It's not a secret, and they've gone to other places and operate in other regions. And they operate in those regions as a CMHC. Operate in those regions as a BHSO, and life is good. We provide the crisis management 24/7 for their clients in other regions.
I'll talk to you more about this later. Thank you.
It's
Chair
a
Ladies,
sensitive
for
issue at
indulging.
my Carp meetings.
Pardon?
It's a sensitive issue at my Carp meetings.
Okay, thank you.
Okay.
Okay.
Please proceed.
So that's the map of who we are. And again, briefly, October 31st, 1963, last legislation President Kennedy signed before that fateful day in Dallas. Dan Howard says he was there, right? I don't know if anyone remembers Dan Howard. Unfortunately, he passed away in November. He wasn't one you argued with, right? Dan Howard played football for Bear Bryant and basketball for Adolph Rupp and worked with President Kennedy on CMHCs. There's no one else that fits that criteria, in my opinion. He came home and got busy getting our system started and created this. So President Kennedy, when it was signed, a good job well done. I still think it's a good job well done. Kentucky was the first state to complete the network. We had everyone covered under CMHCs. That's my history lesson. More of that. Let's talk. This is the Smi Task Force. Let's get a definition before us of what SMI is. And this is SAMHSA's definition and our Department of Behavioral Health definition. This, they just cut and paste this information. But SAMHSA talks about individuals 18 years or older, a diagnosable emotional, behavior, or mental disorder, not specific, that causes the decreased functioning and lasts for up to a year, roughly. That's the SAMHSA definition. But it has age, it has diagnosis, impacts functioning, lasts for a year. Kentucky's definition, 18 years old again, diagnosis is the schizophrenia spectrum, bipolar, depressive orders, and trauma and stress. So we're more specific. I think that narrows who we define as a person with mental illness. And it looks like Representative Wilner agrees with that. It's narrower. But it still impacts functioning. And in Kentucky, it's 2 years. So that's who we're talking about. That's who we want to focus on. That's who we do. CMHCs serve about 43,000 people with this diagnosis annually. 43 of 175. About a fourth of who we serve meet this criteria. It's about 1.4% of the adult population. Did a needs assessment for another project. That needs assessment indicated the prevalence rate for SMI is 2.4. So we're missing about 1% of the adult population to get to that number. So we're about 60% of where we ought to be. So there's people out there, hopefully they're seen by somebody else. We know they're seen by primary care. They're not necessarily getting a full array of services. If they're not accessing services or not being seen by someone, these folks don't disappear. They don't disappear. You're going to hear from mental health court. They're there. They're in jail. They're in ERs waiting for services. They're in homeless shelters. They're on the street. They're worse off than that. They're attempting suicide, all sorts of things, if they're not accessing care. And that's what I think this agenda is all about today. How do we access care? So let me tell you the services CMHCs have, and they're in front of you. Standard BHSO has these services. Assertive community treatment, that's a team approach. Multidisciplinary team heard about earlier, has a prescriber on it, maybe a psychiatrist, maybe an advanced practice registered nurse, has a therapist, a case manager, and a peer support person. And they go out to the community is a really effective urban model. It's more challenging in rural settings. But they go out, rural counties, a lot of regions have it in 1 or 2 counties, not across the whole region yet. That's a start. But they go find the person, give supports, as opposed to waiting to show up. Addresses transportation, addresses people not accessing services, which has always been a concern. Targeted case management. This is we can't use the word social worker because not all social workers, so they can't be licensed that way. But these are folks who work with individuals. They know where they live, they interact with them, they connect them to resources, food bank, renting supports, whatever it is. These are really the boots on the ground people at CMHCs and other behavioral health services. We have an army of targeted case managers. Communities, comprehensive community supports. This teaches skills people need to live in the community. It may be understanding their illness. It may be accessing care. It may be making sure their bills or groceries are done. These are skills people may not have. This is an opportunity. The next one is peer support. This is just an awesome service. I suspect you'll hear more about that maybe. The best example, these are people in recovery who are doing well, well-stabilized, functioning well, been successful based on Dr. Mccarron doing that. They're helping other people who aren't there yet. The best example is a gentleman who had frequent admissions to one of the state psychiatric hospitals we saw earlier, went back home, got service and support, is now helping people stay out of the hospital. He went from being admitted frequently to now keeping people out of the hospital. He has a full-time job. He's earning benefits. He's a homeowner, supporting his family. That's what peer support can do for people. Pretty significant. Supported employment, put people to work. That's what that's about. Not a Medicaid service. These other Medicaid services. State General Fund pays for that. Got some grants. Department of Behavioral Health will really help with that as well. Therapeutic Rehabilitation is a day program. 3, maybe 5 hours a day, 5 days a week. You go again. Setting, you go to a building, you learn either just skills to support yourself in the community, cooking, cleaning, all those things you need to live on your own independently. Some have changed from therapeutic rehabilitation to social club drop-in. You go and there's groups and you learn skills. I think there's a lot of successful programs with that. Crisis stabilization units, mobile units. We provide those services. That makes us unique as a CMHC doing this crisis stabilization. That's a 24/7 service. It's designed to keep people out of state psychiatric hospitals. It's also a step down from state psychiatric hospitals. You get discharged from Eastern State, Western State, Central State, you may end up at a crisis stabilization unit. Mobile is they go to where the person is. It's not a building. One center did this with children's services. They're focused on putting a staff person in the home in a crisis or putting the individual in like an overnight foster care, a couple of nights. But their goal was to keep the kid in their school district. So they didn't miss school. 12, 14, 15-year-olds didn't have to explain to people why they were gone for a week. So they kept the school. That's the mobile model. Medication administration, heard about that. Outpatient individual delivery, kind of typical services. That's the core services CMHCs provide. All right, let's talk about challenges and opportunities. I think the biggest challenge we continue to face, have faced for a long time, is stigma. People with a severe mental illness have a hard time finding a place to live. Landlords don't necessarily want to rent. Okay, they have a hard time getting jobs. They're not welcome. I've had stories told repeatedly where staff got calls from grocery stores. Your people are here, and they're causing problems. And a guy I worked with would always say, I don't have people. They're not my people, but they're not welcome. And that's stigma, and that's a persistent, ongoing problem. And people are reluctant to access services, reluctant to go places. They're not always welcome at primary care center Alvarado. Some folks don't want to see them, and we work on that. We try to make that better for folks. So that's the biggest challenge. Another one is MCOs. We've had a decade of managed care in Kentucky. I'd like to look at the effectiveness of managed care, the prior authorization process. I know that's going to be discussed tomorrow. That takes time away. Our clinicians are offline getting services approved and making sure this happens. Now, those were suspended during COVID. That's wonderful. They're still suspended. But prior, we had the best people, some of our best clinicians offline getting prior authorizations approved. It's a common practice. It's really hard. You got someone who's in your office for the first time. It's a big step to access services, and you say, can you wait? We'd like to start you. We're going to do that, but we want to make sure we can do that. So that's still a problem. Payment from MCOs. I have monthly calls with MCOs, and we struggle with payments. The worst situation are people who are dual eligible. They have Medicare and Medicaid. Medicare is almost like stigma. Doesn't pay for all services Medicaid pays for. Doesn't pay for all classes of professional. They pay for psychologists, licensed clinical social worker, not master's levels in psychology, not licensed clinical counselors. They won't pay for that. They see that person. We're told you have to bill Medicare. Medicare will not communicate with you on a person they don't support. It's not on their panel. They're not going to send you anything on a licensed marriage family therapist, certified social worker. They're not going to do that. They're not going to send you anything on targeted case management because they don't pay for targeted case management. They don't pay for day programs. They don't pay for it. We get nothing from it. So we've gone back and forth with MCOs on this issue. You're almost at a disadvantage. We've got two insurances. You're better off just having one. We can manage that better. Hopefully we have that resolved, but I've been at this thing for 10 years now with managed care. We don't know. That's an ongoing struggle for us, how to make that happen. I want to say COVID-19, obviously. We've had a really hard time. The expansion of telehealth sustained CMHCs. There's no doubt that's the case. I suspect it sustained a lot of providers. That opportunity that were given to us by the Cabinet and Medicaid and behavioral health to make sure we were seeing people, and some were on phone, which, I heard from many clinicians for a kid in crisis or a family member in crisis, a phone is a great way to communicate with the clinician as opposed to waiting to your appointment or doing FaceTime or getting on. So I think that really changed health services. Adolescent boys love telehealth. They're familiar with the technology. They feel good about it. I also think they didn't have to explain to anybody where they went. Their friends, when they disappeared, went someplace for an hour, they didn't have to tell where they were at. I went home. Okay, that's kind of a common thing. Really a big deal. We have to figure out who is telehealth best for, what staff are most effective at it, and remote services. But telehealth saved us, so we hope that's going to continue. Two big opportunities I want to talk about in closing. One is a certified community behavioral health center. This is essentially a CMHC in the 21st century. This is a result of work at our federal partners for a long time to make this happen. And what it is, you have core services you have to provide. And those are your list in front of you. We do a lot of those services now. We don't do nearly as well with primary care stuff. We do some primary care. We're getting better at it. One individual told me their primary care, they have a couple, 2 or 3 APRNs who fill in the week, diagnose someone with cancer. Wasn't happening before. Convince someone to get the COVID shot. They were afraid of needles. Don't trust anybody. They're now accessing, they got vaccinated. These are all things that we now do in pieces. This would require a CMHC to do this. We would have to have this relationship or do it ourselves. You heard earlier, people die. People who are severely mentally ill die 25 years earlier, primarily due to treatable stuff. Why do we tolerate that? A lot of it really relates to social determinants of health, where they've lived in and out of homeless shelters, exposure to hepatitis, not taking care of themselves, not seeing a doctor on a regular basis. This has been a real barrier. The CCBHC forces us to address that. We've talked about it. We've networked with local primary care providers. This puts us clearly in place. We have to do this. This is a big deal for Kentucky, in my opinion. This all started in 2015. There was planning grants. 24 states got planning grants to implement CCBHC. 2016, 8 states got awarded a grant from CMS to be a part of the demonstration state. Kentucky was not included in that. COVID funding in late winter, early spring of 20 expanded it to 10 states. Kentucky was, in my opinion, number 9. Michigan was number 10. We were included in that. So we now have an opportunity for the 4 centers that were identified in 2016 to make the transition to be a CCBHC. That requires additional staffing. It requires really understanding how to provide primary care, make those connections to people. It's care coordination.
Another minute or two,
Okay.
and then we've got a question.
Okay. Yep. The care coordination piece is significant. We want to partner with KHI. The vision that we have is someone shows up at the ER inappropriately. Through KHI, someone on call to the mental health center gets alerted they're at the ER, shouldn't have to be there. That's what care coordination is. You stop ER uses where people don't need the ER you save your money, right, Senator Meredith? That's going to take care of a lot of that piece. A lot of our folks show up for no reason. So that's the piece of CCBHC. We were hoping that would go live October 1. It now go live January 1. Heard from the cabinet January 1. We're going to have 8 quarters of that. So we're going to go January 1 of 2022 through December 31 of 2023. And those centers are 7 counties, Louisville, North Key, Northern Kentucky, Pathways in Ashland Moorhead, and New Vista in Lexington. So those 4 have been working hard to get this thing in place to be a CCBHC. Our objective is all 14. What has happened recently in Kansas? They passed legislation directing their equivalent of a cabinet to create a CCBHC for their mental health centers to become that. Because what happens is more people are served, more staff is hired, more services are provided to people. The last thing, I've said this before, an SMI waiver. Hopefully you've all heard me talk about an SMI waiver. It goes back to June of 2019. HCB waivers for people who are aging, people with physical disabilities, people with brain injury, people with intellectual developmental disabilities, and there's an 1115 waiver for people with substance abuse. There is no waiver for people with mental illness. A waiver can provide services to a targeted population and a smaller number. It can include a residential option. People can live 3 people to a home, like in the SCL waiver, with 24/7 supervision. 12 hours in a home, half-time supervised, live with someone, make sure those things happen. Also provides for employment. It really allows people to have a home and get a job. The other thing it does is make sure medication is taken. In the SCL waiver, if you are 1 hour late on prescribed medication, that is an event you have to report to the cabinet. If you're SMI, and I've said this to other groups, if you're 1 hour late, 1 day late, 1 week late, 1 month late, no one knows. It's not working. It hasn't worked. We have to do better. I tell you who knows. Neighbors know, families know, law enforcement know. We have to do better, and I think we can do better. And those are 2 opportunities that will meet the needs in a better way than we are now for
Steve,
folks with
thank
real mental
you.
illness. How'd I do?
You did really well. You did really well. And we do have some questions, or at least one. Representative Bentley?
Thank you, Chair Lady. For the sake of the committee, what is MCC billing?
Managed care.
Okay.
Did I have MCC?
Mm-hmm.
It was stupid. It was MCO.
Okay. My question is then, can a BHSO bill as a CMHC on MCC billing?
MCO, managed care billing. They bill as a BHSO, as a behavioral health service organization. That's a recognized thing. The MCOs, managed care organizers, recognize that. So they bill under their license number as a behavioral health service organization.
Can they bill Medicaid that way?
Yes, they can.
Okay.
Fee-for-service, Medicaid, and the 6 MCOs.
Okay. The second thing is, on the stigma, I'm hearing a lot about ambulances not picking up people with mental illness stigma.
That is an ongoing problem. And if you read the statute on ambulance transportation, if the person is ambulatory, they don't necessarily get a ride in an ambulance.
Okay.
And that's happens. And, you know, the involuntary commitment process, you heard about that, it's a 202A. Those individuals who are in acute psychiatric distress gets transported to a state psychiatric hospital in the back seat of a cruiser. That's how they get there, the back seat of a cruiser. No one rides in the back seat of a cruiser by choice. No one with a physical illness rides in the back seat of a cruiser. But for some reason, if you're severely mentally ill, we'll put you in the back seat of a sheriff car and drive you.
In handcuffs.
In handcuffs. Why would we do that?
Thank you, Director, and thank you, Chair Lady.
I don't see any other questions. We're glad to have Senator Berg know that you've been in another committee meeting, and since we don't have cloning in Kentucky, it's hard to be 2 places at one time, isn't it? Steve, thank you for being here, and I know that you're always willing to keep the conversations going with these members. And I have some really good friends here with me today who are here to introduce one of their really good friends. I have Kelly and Phil Gunning, and Phil is the executive director, if y'all want to come on up, of the National Alliance on Mental Illness in Lexington, Kentucky. And Kelly is the Director of Advocacy and Public National Alliance on Mental Illness, and she's also from Lexington. And we have with them today then one of our infamous and very superior judges over in Lexington, Judge John Tackett. Judge, thank you so much for coming and being with us today. I'm not sure who's going to lead the way or how you all want to proceed, but if you would, we'll have you introduce yourself first for the record.
Certainly. I'll go ahead and introduce myself. Sure. News to me, I was superior. I'm district court, which if you're familiar with the district court, that's at the very bottom of our totem pole, so, but I appreciate the good, positive thoughts about the superiority. Again, I'm John Tackett, and I'm District Court Judge, 5th Division of Fayette District Court. Now, I did want to ask you, Senator, how much time do we have to present?
What we had allocated was about 15 minutes total.
Okay.
So is that what you thought, Kelly? Is that what
we
you
thought it was
thought?
more than that, but that's okay.
We thought it
do
was
it.
15 minutes each.
We'll do an abbreviated.
Oh,
jumping
okay.
for joy.
Okay. We have to leave this room, and so you can each take 15 minutes. I think that's what you all had been told in advance. Who wants to go first?
I'll go ahead and present then. Thank you. Again, it's an honor to be here, and it's a real pleasure for me. The Fayette Mental Health Court was founded upon a concept of criminal justice reform to promote human dignity, restore personhood, and decriminalize mental illness. These values and actual goals are embedded in every facet of our court process through a fidelity to therapeutic justice. Participants are accountable to our court, which includes personal and societal responsibility to become a leader in their own lives and to install a spirit of health, stimulation, sobriety. Moreover, many people with mental illness want the assurance that they have been heard, and this court provides them with that opportunity. Throughout Lexington-Fayette County, our police, attorneys, judges, medical providers, and mental health professionals have all demanded an alternative for those who suffer from mental illness to get the care and resources they need. One key difference between our court and other models around the state is that our court is comprised of almost entirely NAMI advocates, the same peer support that Mr. Shannon was speaking about earlier, as opposed to state court employees. A Supreme Court establishing order, signed by Chief Justice Minton at the founding judge's request, allows for NAMI advocates to serve in this capacity. This allows for a more specialized advocacy from our team beyond the restraints that state employees find themselves tethered to. Essentially, this team can advocate for participants where many state employees cannot. We have been fortunate so far to have this model funded through the Lexington-Fayette Urban County government throughout the course of our operation. Our staff, again, run through NAMI, receives referrals from law enforcement, prosecutors, defense attorneys, and judges to intervene in the lives of criminal defendants who suffer from diagnosable and serious mental illness. An overwhelming majority of our participants are duly diagnosed, suffering from both mental illness and drug and alcohol addiction. Most of the individuals we serve have been flagged by law enforcement because they have long history of criminal recidivism, are unemployed, and are unstable. Many of the court's participants, due to their vulnerable condition, have also been subject to victimization themselves. Many of our participants were subject to sex and human trafficking. Many have suffered through long periods of homelessness. A few have been abandoned by family and friends and have not experienced the high level of nurturing and support to become stabilized until they reach our court. Our court is equipped to provide our participants with wraparound services to address their mental health needs and generate recovery from their addiction. Our aim is to lead participants to a life of stability and lawfulness and hopefully gainful employment. While this court has only been in existence for a few years, it has done amazing work and provided stability to many repeat offenders. Our success rate is remarkable. It really, truly works. Our participants often find stability while involved in the program. For those of you who serve the Commonwealth but may not be well acquainted with this side of our justice system, I wanted just to provide you with an example of a typical criminal defendant with a mental illness, and let's call her Ashley. Ashley suffers from serious mental illness and is arrested for violation of a domestic violence order for contacting an estranged family member. Her pretrial report reflects she's a high risk for not coming to court, so the judge will impose a bond she cannot afford. Ashley is ordered to be assessed for her competency to stand trial. After at least 1 week in jail, New Vista, our local community health provider, makes a preliminary determination that Ashley may not have the ability to understand or rationally participate in the court process. New Vista recommends the judge send Ashley to Eastern State Hospital for a formal evaluation to be performed by a licensed psychologist. It takes 2 months to obtain a formal competency report where either Ashley is at FCDC or Eastern State at approximately $120 a day. The Eastern State Hospital report issued by the psychologist finds Ashley unable to participate in her defense and lacking the requisite mental ability to understand the criminality of her action. A week later, Ashley's defense attorney and the prosecutor move as a matter of law for Ashley's case to be dismissed. At this point, Ashley's been held in custody for approximately 3 months. Ashley is released to the street, likely untreated or marginally treated for her mental illness, unstable, and having lost her housing. Ashley is next rearrested within a week for violation of a domestic violence order for contacting an estranged family member, and the entire process will start over again. Without community supports, Ashley, like so many others, will continue to spiral down into a life of repeat criminal activity, homelessness, possible chronic drug and alcohol abuse, and possible victimization. This court is designed and meant to intervene in lives such as Ashley's and break that destructive cycle. Our court is run through an intensive case management program, holding participants accountable through the black robe effect. Our team would transition a participant such as Ashley through 4 phases: stabilization, treatment, self-motivation, and wellness. And I could speak to those in detail if you all want me to pursue that, but in the interest of time, I'm going to skip and just tell you that each phase basically lasts about 3 months, at least a minimum of 3 months. Our team performs a never-ending array of services tailored to the uniqueness of the client and their needs, ensuring that they maintain doctor's appointments, psychiatrist and psychologist appointments, help navigate insurance and government resources to pay for mental health services and medications, ensure housing needs are met, and the participant is working towards stable housing, guiding a participant to group meetings and mental health programming, ensuring participants are medically compliant, drug and alcohol testing to monitor medications and prevent catch relapse, keeping participants accountable and advocating when necessary, and also, of course, helping guide that participant to employment if unemployed. We conduct court each week, which involves 2 hours of staffing. Our team is comprised of myself, an assistant prosecutor, team members who are, as we said, mostly peer support, and NAMI advocates, community licensed psychologists and experts from Eastern State Hospital, New Vista, University of Kentucky graduate students, and an officer from our adult probation office. We also work in concert with CIT trained officers from the Sheriff's Department and police. Fortunately, our team is made up of so many representatives from our local community that we can share information about persons of concern with mental illness concerns, and we can coordinate our efforts. After staffing, we conduct court. I can just tell you that I wear a number of different hats as the judge for the mental health court. I am a cheerleader, enforcer, advocate, strategist, counselor, coach, promoter, but most of all, I just try to be the very best listener and encourager for our participants. Without a doubt, Wednesdays afternoons, which can last anywhere from 5 to 7 hours on, it just depends, are the most challenging time I spent in my work week. To keep participants accountable, we employ sanctions. We call them electives. They are therapeutically grounded and informed. It can range from additional group meetings, more frequent drug or alcohol testing, recovery-related research. Unfortunately, it's a sad reality that we do have to use incarceration, but a lot of times it's always used as a last resort. And may be employed just to keep a participant safe because there's no reasonable alternative for placement. If that person is experiencing an extremely life-threatening active addiction, or if the person is at risk for future victimization if remaining in the community. So I would just indicate that jails, they're meant as punishments, and jails are intended to have a negative impact. Naturally, the atmosphere of detention centers runs counter to treatment or helping anyone's mental health. I certainly don't want to be there, and I don't think you all do either. So it is viewed as a last resort. Many of our participants can be engaged in this program for longer than a year. Upon successful graduation, that participants have been sober for at least a year, and the criminal charges are ultimately dismissed and their records are expunged. Unfortunately, to provide these services, we are forced to limit our capacity. Our local defense attorneys and prosecutors understand that we have a long wait list for placement. Additional funding would undoubtedly expand this court's mission and achieve more assistance for more defendants. If additional funding was available, judicial resources would be allocated to meet the demands of more participants in a bigger docket. We see a need for an aftercare program. I'll say that just briefly. That we typically, without that accountability, relapse is definitely possible, and that would be run through peer support and our graduates. Again, thank you very much for giving me the opportunity to speak to you all. I would extend each one of you an invitation to come visit us and step into staffing or our actual court or both. We've had a lot of council members that have sit in, and the same invitation would be open to you. And I'd be happy to answer any questions after we're concluded. So, Kelly.
Thank you, Judge. And we really would. I wish so much that we could go over. Maybe it would have to be one at a time, or
with Zoom we can. We're doing hybrid as well too,
true.
So that would be definitely an opportunity for you.
Well, that's something for us to think about. I think that would be very helpful. I'm going to go ahead and let the next one of you speak, and we'll take questions at the end from each of you. Phil Gunning, come on down.
Thank you all for this opportunity. Of course, I get to, as usual, follow these outstanding presenters, and I need a PowerPoint to do what I'm doing. I want to show you, though, just a little bit about the nuts and bolts and the return on investment.
Can we check to see if you've got your mic turned on, the green
Just
button?
needs it closer, I think.
Just closer.
Check.
Is the green button on?
There you go.
There we go. Okay. Okay. Judge mentioned our team. We have a team of 10, and that includes judge, prosecutor, and public defender. And then 7 folks who are all family members and or consumers of mental health services.
And
In addition to that, many of them are professionals. We have a lot of letters in our team, LCSWs, MSWs. We have people with multiple bachelor's degrees in corrections and mental health. So it's a pretty outstanding team. But again, the fact that these folks all have lived experience is what we think is the magic of this model. I won't go into this picture in great detail other than to let you know that this was put together by one of our peers who's on the team and speaks to his journey from old life to new life. And you see some things in here, addiction, and then NASW. He's actually on the board of National Association of Social Workers. So he's come a long way. Very important to the team. Our outcomes are astonishing, really. Judge touched on that. This slide here speaks to sobriety, and you can see that all our numbers are way above the national average. And again, I think that is credit to the peers. You just can't be as effective as somebody with lived experience. They can gain the trust of folks where oftentimes professionals cannot, although they are professionals. But this slide, I'm not sure. We had our peer team put these together. think this one just shows some of the things NAMI Lexington's involved in. Steve spoke to Stigma, and this slide, again, was put together by our peer team. We think not only is it stigma that is a barrier to access for the participants, but it's a barrier to access to funding for some programs that are very effective, very innovative, but don't get a lot of attention because it is serious mental illness, and very honestly, serious mental illness doesn't get a lot of attention for funding. And we think that's because of stigma. So stigma doesn't just relate to the participants. This one was made by our court coordinator. She's also a peer, and she mentioned that helping a participant through this journey is kind of like helping them climb a rock wall. There's so many different things you have to touch on, and you see the Fayette Mental Health Court person down in the bottom providing the security and the support for them to go through and touch on all these different services and benefits that they need. In the middle, you see a mental health court participant. On the outside of this wheel, you'll see a number of services. We're pretty fortunate in Fayette County that we do have a lot of services. What you don't see is any connection between this participant and these services on this slide. And the next one, you see spokes. The mental health court team helps the participants connect to all these various services and stay connected to them. They teach them the skills that it takes to remain compliant and to stay in touch. Judge mentioned accountability for the participants. This team also, this spoke system sort of works two ways. This team also is a team of very headstrong advocates, and they make sure that there's accountability on the service side too. Steve mentioned some of the challenges with the MCOs, and we're constantly testifying to those challenges because they're front and center, with our population every day. This is another slide that came from some of the peers in recovery, but also from some of the graduates. And I want you to know notice the different language in this graduate slide compared to the one relating to stigma. People come out of this program empowered, a lot more self-confidence, a lot more skills to keep moving forward in their recovery. This slide shows some of the outstanding outcomes that we have. I think when you have 75% of participants coming into a program unemployed and 71% leaving employed, that's pretty outstanding. In addition, the rest of that population are engaged. If they're not employed, they are engaged in volunteer services. They frequently are reconnected with their families and communities.
School.
So, many of them back to school. Mm-hmm. So their lives are back on track. This speaks to an investment that has an incredible return. We've been doing this for 20 years now, Kelly and I, and we've developed a lot of programs. This one still blows my mind on the money side. From July 1, 18 through December 31, 2020, we had a total of $455,000 in funding. The Fayette County Detention Center has an average per diem per day of $72. So this slide speaks to the number of days of incarceration that were diverted in that time frame through the mental health court, and the total savings of $3,115,800. That alone is a heck of a return. But this next slide, I think, is even more interesting. The Treatment Advocacy Center tells us that folks with serious mental illness cost correction centers 60% more in resources to serve those people on a daily basis. So if you look at that, and that's bound to be real. These folks have so many things going on. If you look at that and figure what the per day cost to Fayette County Detention Center is for someone with serious mental illness, then that savings pops up to nearly $5 million. The next one is a little hard to come by. We had to go with a national average. Each program graduate saves law enforcement $5,716 a quarter just by being removed from the recidivism and the constant calls that law enforcement has to make with these individuals. As of December 31, we had 263 postgraduate quarters, so $1.5 million worth of savings to law enforcement. Put those two together, you're looking at nearly $6.5 million in savings on a $455,000 investment over a 2.5-year period. Again, our graduates are not only back on track in their own lives, but many of them are providing mentoring and peer support services to others. They're contributors through their employment. They pay taxes. They're members of the community again. The value that they create is ongoing, just like the savings, the cost savings are. So these numbers, it's time to update this again. We've just got another quarterly report so we've got 6 more months of data. What's fun for me is every time I go through and update this, the numbers just get better.
Well, you all are doing magnificent things, and I'm just so proud of you and all you have been accomplishing. And as you say, these numbers speak for themselves. Kelly?
Yes, I just want to speak to you about how the mental health court, we took 2.5 years of a community decriminalization committee to develop with decision makers from law enforcement, criminal justice, mental health, primary care. You asked who was there. It was everybody that touches these individuals. I want to let you know that in that 2.5 years, Connie Milligan and I and Judge Wilkie really drove this train. We really drove it to Judge Minton and the Honorable John Landon, who helped us create the regs for our court, which are different from a drug court. I want to make a very distinct difference between those two things. Even though 80% of our clients right now in court have a co-occurring substance use disorder and serious mental illness as outlined by Mr. Shannon. You saw what those serious mental illnesses are. These are illnesses that have devastating life impacts on these people. So take the serious mental illness by itself alone and add horrible substance use disorder. And what I'm talking about in our court, and Judge can attest to this, they're not only on heroin, they're on methamphetamine, which is being cut with fentanyl. They're smoking weed, and they're drinking alcohol. So they're quadruply addicted. That's polysubstance use 101. They're the poster child. Why? Why are they using all these drugs? Because what came first was the serious mental illness or trauma. So not only do they have serious mental illness, they have serious substance use disorder, polysubstance use disorder, and they have trauma on which all of this rests. We have people in our court whose stories would curl your toes. I'm going to tell you just 2 briefly. One was a young African-American male who was given to drug dealers by his mother at age of 3. Now, what do you think drug dealers did with a 3-year-old kid? Okay, so that picture's in your mind. The other one was a young woman who was growing up in the foster care system for her whole life, kept repeatedly running away from the age of 12 on. Guess where she ended up? Prostitution, sex trafficking, domestic violence, abuse, jail, over and over and over and over. The recidivism rate with these folks initially is through the roof. We're seeing them every week, right, jail, right before this? So we have the sickest of the sick. So they have serious mental illness, polysubstance use disorder, severe trauma. Many of them have traumatic brain injury from the result of their trauma and living on the streets. They're homeless. They have physical disabilities, and they have intellectual developmental disabilities because they were never nurtured or raised in a loving environment. How is a kid that was taken at 3 years old and given as a down payment for drugs to a drug dealer ever going to grow up normal, go to school, be able to learn? In trauma, what happens is your brain goes into overdrive in your amygdala, which controls your fight or flight responses to life. You're only being driven by survival. Those chemicals go haywire in your body for long, long periods of time. Cortisol, adrenaline, norepinephrine, all those chemicals that create stress responses. So when you begin to get old enough and you're feeling uncomfortable and you're getting in trouble at school, you start smoking a little reefer. You start smoking weed. Maybe you're getting into the liquor cabinet at home. Maybe you're really escalating quickly to hard street drugs. You're not going to have much of a chance. Our program takes all of those things that comes to us in these individuals that Judge described, and we start wrapping around what they never had, we give to them. This is a way of doing mental health court that was started by Judge Ginger Learned Wren in Florida. I'm a disciple of hers. I've talked to her on the phone. I've read her book. I've done everything that she tells me to do. And her words for what we're doing are called therapeutic jurisprudence, different from a drug court, non-punitive, really meeting people where they are, really finding out that they're going to need everything on that spoke wheel, all those community partners. This mental health court in any place in this state will not survive if there's not strong CMHCs. Representative Bentley, they are the backbone, not the BHSOs. The CMHCs that know your communities, know your people, they're regional, they're empowered, they're quasi-governmental, they're not going away, hopefully. We can't operate without the upstream and downstream crisis services and services that these individuals will need for the rest of their life. And you look at that and you go, the rest of their life? Well, they've been through a lot. For them to continue to work, they're going to need support. When they have children, they've never been parented. They're going to need to learn how to parent. So yes, it's a lot. But look at the money we're saving. What you heard from Dr. Mccarron, what you hear from Senator Alvarado and all of us all the time, these solutions don't cost more money. They don't. And they have real results. What we need to stop doing is paying for programs that don't work. These are evidence-based practices that work and are proven to save tons of money. But that's important because we have to work and live in the real world. But what you really have to think about is the human cost. Many of you know that Phil and I were almost murdered by our severely mentally ill son in 2016. We were brutally attacked while we were getting ready for work one morning. Our son had severe paranoid schizophrenia, wouldn't take medicine, never was compliant, and he almost took us out that day. Well, he ended up where? Prison for attempted murder. He's not ever had any treatment in prison. We've cost shifted all of our mental health costs to the criminal justice prison system now. So we need to cost shift back and look at some of these silos and see how can we help each other. How can we really stop sending these people like the 3-year-old boy that was given to a drug dealer so he could just be his play toy? How can we get him out of that system of jail and prison and the street and back? So we need this whole system. When you saw on that slide that Phil showed you with the graphs of the drug substance use and abuse, where was that one? I was going to pull it out for you just real quick. You'll notice in the last couple of years, those graphs weren't as big as the first year. See that? You see these two, how they go down a little bit? They're still huge and above the national average, but the reality is that's a funnel. There are so many addicted and co-occurring and sick substance use people out there that they're clogging up the treatment lanes. And like what Dr. Mccarron and Dr. Alvarado and Steve have said, we don't have enough providers. Then you get someone with serious mental illness, and we're trying to make referral calls to places that are supposed to treat people that have both co-occurring and serious mental illness. As soon as they hear that you have someone with a paranoid schizophrenia diagnosis and you want to send them to their treatment center that's supposed to be a parallel treatment center or an integrated treatment center, click. They don't even talk to us. So to find that level of specialty treatment is non-existent. We need true integrated treatment that the CCBHC model will provide. That's called no wrong door. It doesn't matter what you've got walking in to see me, we're going to fix it. And that's how the mental health court is. And if we can get all of the community mental health centers on that same page, then we can do what the Department of Behavioral Health has asked us to do in our upcoming contract for the next 2 years, which is to start at least 2 more mental health courts in the state of Kentucky using this therapeutic jurisprudence model that we've proven to be so effective. So I would just like to open it up to questions. I know I'm intense, I know I'm passionate, but I've got to fix for all the other people what wasn't in place for me when my family needed it. So forgive my intensity, and I won't apologize for my passion. You guys are doing God's work with us. We love you. We appreciate you. We know we have huge advocates on this team, and we're right there with you fighting every step of the way. Thank you very much.
And for Kelly and Phil, they were fighting for this long before their son almost murdered them.
Yes, we also got Tim's Law passed.
Yes. So they've had lots of successes here and have realized the need for a lot of these things. And we need to take heed. We need to listen to these
They
folks.
will work. If you build it, they will work. And they will save you money. They'll save the detention and the criminal justice system's money. When we went to LFUCG for our funding, they told us that the detention center was a black hole because of the cost to treat people with SMI that are incarcerated. So if we can alleviate that, we should.
Senator Meredith's got a question, I think, and you can direct it to whoever that you
we can
want to
all
hear
answer.
from.
Well, thank you. First, I want to thank you for your presentation, and I don't think you ever have to apologize for the passion you bring to this committee, particularly with the members that are here. We share in that passion and appreciate the work you do. I think you may have answered my question for me, but I just want to make sure maybe you can validate it. First, I want to congratulate you on your vision. Secondly, on your success. It's obvious that it is, but I was going to ask, what are the impediments that you now face? And what I hear you say is access to services and resources. Is that a fair
Yes,
summation of that?
Access to funding. So far, we've been fortunate in having Fayette County, Lexington, Fayette Urban County government fund us, but we're down to having used 3 or 4 different funding sources within their government budget, and we don't have a line item in their budget. And so it would be really nice for a judge to be able to plan from year to year whether or not we're going to have the mental health court, and to be able to stabilize that somewhat. We've been very inventive in going after funding, and we use braided funding sources.
Judge, are there any administrative hurdles that you have to jump through that possibly we need to address?
Well, I guess at the forefront, when I look around the room when I'm doing court, I'm the only AOC employee in the room. I don't have a clerk or anything like that. But I've stressed the positives of that, as far as this peer support model that we're built upon. Administratively, we've made it work. I'll just say that. I think more to circling back to Kelly's point, it's a matter of the funding. If the funding was there to support this model, we can certainly, we'd be able to seize over many, many hurdles. So, and it's really about our dockets too. And I'll just reiterate the waiting list. I mean, this is unfortunately for us, we've got folks, it's a long program. And of course you all are familiar with mental health. It's fluid, and to get someone stabilized, it's not going to be 30 days. It's not going to be 90 days. I mean, we're looking at, a year. And so, it's common that our people are in the program a year, 2 years to get stabilized. And that takes up a space for a referral. So, we can only help so many because we've got such, so many resources to help so many people. But we're getting referrals all the time, and we just have to say, look, we have to wait. We don't have a spot available for you. And of course, with funding, we could, we could run 3 mental health courts.
We could.
Within Fayette County, and there's judges there that would jump at a chance to have their own mental health court.
And we just helped start the first ever in the state. We'll be starting in Fayette County, the first juvenile mental health court. Why is that important? Because we want to get upstream. We want to start when these kids are young, before they get indoctrinated to, gangs and drugs and violence. And they've already got huge trauma histories. Their ACEs scores, which measure trauma, are through the roof. They're all 10s. So we want to start early. So Judge Lindsay Thurston is going to be doing it with Judge Melissa Moore Murphy. We'll be starting the first juvenile treatment court any minute now. We were able to secure $100,000 in startup funding for that juvenile treatment court through LFUCG based on the success of the Fayette County Adult Mental Health Court. So we're very thankful and excited about that. I will say we started this court with no money. Was volunteer, everybody from the judge to every single person. And by our first quarter stats were so good, we were able to go to the council then and ask for money and have a proven outcome record by that point. And we started that with funding from the NAMI Walk, Senator Kerr. So, if you build it, they will come and it will work.
Thank you. I appreciate your, pioneering this for us. It certainly is a great model, and I appreciate your commitment to it and testimony today. Thank you, Madam Chair.
Dr. Alvarado.
Thank you, Madam Chair, and thank you all. I mean, passion is not a concern. I mean, people on this committee, all pretty passionate.
I know.
Medical folks, it's what we're used to, and that's, we all share in that. When you talk about people getting into the criminal system and it's a black hole, generally society has liked it that way, right? These folks are out of mind, they're out of sight, they're out of mind. I don't have to deal with them. There's not someone in a public setting where I have to be uncomfortable and witness something and see something. And so for a lot of folks, that's always been the kind of the standard. It doesn't work. I mean, it doesn't fix things. And having been a jail doc before, and again, a lot of providers are just uncomfortable.
Sure.
Even in CMHCs, you'd have to have a heck of a lot of those to handle the volume that we need. Yes. So there's going to have to be and I think Senator Meredith kind of took my thunder a little bit, is to ask, we're in these task forces, we need to have solutions. We're asking people that present, what is it that you would like to see happen? because we'll have recommendations at the end of this by the time we get ready for the next session, and hopefully some bills to propose of things that we can do. Sometimes those things are heard, sometimes they're not, but and we know that a lot of investments in healthcare is typically, again, it's an ounce of prevention is worth a pound of cure. It's often just convincing our chairman of our budget committees, when they say that, they go, we've heard that before, and they don't often believe it. But if we have statistics to show them, to say, hey, look, just a little bit of investment here is going to have a lot of back-end benefit, to have those recommendations. And again, if they're doing it in Fayette County for a couple $100,000, I saw on there just to manage this, say, hey, look, if we could open up a bunch of regional mental health courts around the state who could help with these things, that'd be of benefit. And just when you mention about, kind of adolescent or kid, I remember just most of your schizophrenics start showing signs at the age of 12, 13,
yes.
something
even
happens.
Younger now.
You start seeing odd changes, typically in junior high. And a lot of those kids will exhibit behaviors. Some states are starting to take it on themselves to also start screening and identifying those kids early and start interventions early. And again, all that takes investment and money, and that's always the hard part of it. So if you guys have recommendations to say, hey, this much would operate this many courts, we would ask this much from this committee, just something in writing would help us. So when we get
are
ready
happy to do that.
Yeah,
and we've been charged, as I said, from DBH did to do that. And we'll do it and share it with you. Happy to.
That'd be wonderful. And if the courts could even offer some of that, that would be helpful, just to say this is what it would require. And if we have judges who are willing to do it, and again, it's just a matter of, with today's testimonies saying we have to have more providers, maintain our CMHCs, more drug courts to help with, or not drug courts, mental health courts to help with a lot of these things. I think it'd be of tremendous benefit. But thanks for your testimony on those issues. That's kind of what I wanted to ask too, is what's kind of the ask from us, because we need that to put together our findings and recommendations going forward.
We really wanted to be sure before we did the ask to make sure you understood how much it works for how little money. If you see the outcomes for such little investment, that's where a lot of the stigma that Steve was talking about comes from in mental health programming, is that people just think it's throwing money out the window. Well, now we can really prove that it isn't, that there are returns on investment when you invest in the mental health of our Commonwealth. And the other thing is, with COVID, the numbers that Mccarron put up are a little outdated. They're low. Overdose is huge now. It's through the roof. It's 50% higher than it was 2 years ago. Madison County alone's up 75%. We've got 35 to 40% of all school-age children reporting serious symptoms of anxiety and depression since COVID. We're sending all these kids in with these amygdala-driven brains to go learn, which requires that your prefrontal cortex be online. Well, your prefrontal cortex can't learn and think if you're looking for a way to get out the window. So, just something to think about.
Representative Wellner, I think you had a question or a comment.
Thank you, Madam Chair. Yes, and thank you guys so much for this presentation and for the work that you're doing. And I just appreciate what I'm hearing from my colleagues too. Just
Me too.
The gratitude for
Me
this
too.
work. So you talk about the return on investment and the money. We're saving this much money from corrections, we're saving this much money from police, and to one of Senator Meredith's themes, the resources are there. We need to have them directed in the right place. So as you're saving dollars from these other agencies, has there been any movement toward reallocating those dollars that you're saving into this type of work?
Phil would like to speak to that because this is his preaching part.
Okay. All right.
We've had meetings and we had discussion. Timing wasn't our friend a couple of times. Our commissioner of public safety in Fayette County was recruited to go with Judge Noble to Frankfurt, and that was right after we thought he was committed to funding the court. On behalf of the jail and law enforcement. So that kind of just fell aside when he wasn't there anymore. I'm talking about Ronnie Baston. And then we had the discussion again, and COVID hit, and it seems like everything's been sort of on hold. So The answer is no. We haven't been able to get there yet, but we have had those discussions, and they've all been positive. And the people who can make those decisions all agree that, yes, this money needs to come out of public safety, because that's where the biggest savings are. There's a lot of other places where we could identify savings if we could get data, but we can't get the ER data from regular hospitals. It's very hard because of confidentiality to get anything from the psychiatric hospital. So there's a lot of different, we think people benefiting from these services, but it's really hard to actually put that on a slide. And
let me just give you a real quick example.
Please
too,
do.
From my
Is your mic on?
It is. I'm just sitting close.
Don't be shy.
Here I am. So at any rate, I'll tell you this. In preparing for today, I went back and looked at some of our, greatest misses. Just some criminal defendants that were really tough cases that didn't succeed. Guess what I found? Even though we've had relapses and folks re-enter the criminal system, a lot of the folks who have been in our program for any period of time and failed have taken away enough skills and enough knowledge to stay out and stay lawful, which is another thing that it's not going to be reflected in the numbers, but you're seeing basically untangible return on investment, because you're never going to find a statistic or number other than a judge who's curious as to how somebody did, pulling up a criminal record and pulling up like CourtNet and finding that person hasn't had a single episode of criminal activity since they were discharged from my court.
And the ERs are a huge thing that we haven't been able to quantify. But Steve, Shannon, and I a few years ago did kind of a mock-up on one of our familiar faces. That's what the system calls these people that they see all the time. And this person's thing was every time they would get in trouble or have a psychotic episode, they would go to the ER. Well, they had been to the ER like 99 times in 6 months. And at a cost that we just using the basic lowest level of an emergency room visit was upwards of $800,000 for one person. We have one person that was in the mental health court that graduated and is working now, and they were being arrested once a week. We don't have that cost reflected here, but they're working now, full-time job, got a girlfriend, engaged, going to make a big life.
As an attorney, I'll tell you, speaking to you as an attorney for 15 years before I was a judge, I remember being a criminal defense attorney before the mental health courts existed and having family members come and say, what can I do? And it's just an amazing tool for our defense bar, for our prosecutors to send a really troubled person to this court to receive those services, which didn't exist, 7 or 8 years ago. So.
Thank you.
Thank you,
Dr. Burke,
Representative
did you have
Wilmer.
a question or comment? I couldn't tell for sure. We appreciate you being here as well, and all these members. And I don't see any more questions, and I know it's about time to wrap this up, but it was a marvelous presentation and a great meeting today from all our presenters. And I think we're getting some concrete information and a way to hopefully to go forward and find some real solutions
and we're
will
happy
work.
to help solidify what that might look like.
Yes.
And come sit in anytime you want.
Okay.
Yes.
I'd really like to do that.
Yeah.
So maybe
I'll send an email to Samir as far as contact.
that'd be great.
Thank you all so much.
What I wanted to tell y'all before we adjourn, and again, thank you very much. We're going to have our next meeting on August 17th at 3 p.m. So I'd appreciate if all the members and staff and others would take note. And I would now take a motion for adjournment. We are adjourned.